This is a 14-minute webcast for GPs and other health professionals. It features excerpts from a series of talks given by cancer specialists to GPs in Tower Hamlets in 2011. The talks coincided with the launch of the Small C Public Awareness Campaign. The aim of these talks, and the Small C campaign, is to improve the early diagnosis of cancer. This webcast is about breast cancer. It's in two parts. The first is about screening and diagnosis and lasts for 6 minutes. The second looks at treatment options and implications for GPs and lasts for 7 minutes. The speakers from Barts Health NHS Trust are Jennifer Hu, oncoplastic breast surgeon, Anthony Peel, breast surgeon, Rebecca Roylance, medical oncologist, Nancy Evans, clinical nurse specialist, and from NHS North East London and the City, Judith Shankelman, senior public health strategist.
So I'll just start off by just giving you a few facts of breast cancer. As you know, it's the most common cancer in women, and 1 in 8 women will get breast cancer in the Western world. There are about between 40 to 50,000 new cases of breast cancer a year, of which about a third of it comes through the screening program.
Breast screening detects cancer early and improves survival rates. The national minimum standard for breast screening coverage is 70% of eligible women screened in the last 3 years. London's coverage has traditionally been lower than the rest of the country, and East London in particular has had low uptake of screening. In March 2008, coverage in North East London, that's Hackney, Newham and Tower Hamlets, was below 55%. By 2011, this had increased to almost 68% after a range of evidence-based interventions, which include GP endorsement and better list management in primary care. Also, outreach by commissioned community advocates and stronger commissioning of the breast screening service.
Age is mainly the most important risk factor. The older the patient, the more likely that a mass in the breast is likely to be malignant.
The bad factors for breast cancer are obesity, a high animal fat diet, a high dairy diet, high alcohol, long-term HRT, and lack of exercise.
Most in situ disease don't present with much symptoms. Occasionally they do present with a breast lump or nodularity or nipple discharge.
The younger age group mammogram takes more time to interpret than the mammogram from an older lady, because it will be more dense, and so the radiologist has to go back and forth, being really certain. So in other words, it is going to be basically quite time-consuming.
In the stage 1 cancer, the survival rate is up in the high 90s. The stage 2 cancer, which is much more of a hodgepodge of breast cancer, it can include cancer with or without lymph node involvement, and depending on the number of lymph nodes and the size of the cancer, the rate drops off quite a lot from upper 90s to the low 70s. But again, I think that one needs to really look at stage 2 is a different categories of stage 2. You get stage 2A and stage 2B. But there is a difference, and obviously if you start getting to the stage 4 metastatic disease setting, not many people do very well over a 10-year period of time.
The overall survival for the UK, albeit that it's not as good as some areas in Europe, is improving. For instance, in the 1970s, the expectation of 1-year survival was 82%. By 2005, that had risen to 96%. So that's a huge change.
In the balance of things, it's, I think, better to overtreat than undertreat, because those women that are going to progress you want to avoid the unavoidable, if you like, and that's just the same with presenting early. By the time these women present with late disease and metastatic, they're no longer curable. So it's getting them at the stage where they're curable.
It's interesting that you commented about some women not wanting to come, and there's an assumption that there's ethnic differences, and actually that was the case 5 years ago, that around 35% of Bangladeshi women were coming for screening and nearer 60% of white women. We're now around 68% altogether, and we did some research, quite widespread. We looked at all of the women who'd come for the last 3 years, and there was no difference between white and Bangladeshi women in uptake, and there's no difference between socioeconomic status in women who come, and nor was there any difference in people who live in different areas, different local area partnerships of Tower Hamlets. So one of the things that's happened is with the big increase, which hasn't been by chance, it's been some very targeted work, getting the right messages to people, we seem to have closed the inequalities gap as well as increasing. And one of the things you mentioned about women being fearful and thinking it hurts was there were different messages for different people. So for white working class women, they didn't want to be told what to do, but they wanted peer reassurance that it's not really painful, it's a bit uncomfortable, but it's really worth it. And for Bangladeshi women, and I just name those groups because they're the biggest groups in Tower Hamlets, they really didn't know. It really was lack of information, and it was clear information and clear instruction from a trusted person, usually a GP or a practice nurse, saying this is important, it's free, it will save your life, and that seems to have made the difference.
If the patient has got early breast cancer, most likely mode of treatment is surgery. And if we can do breast conservation surgery, then this is what we're going to try and achieve. In the UK, not all units are doing sentinel biopsy yet, but at Barts we are. But that's the way to go, because not most women who has breast cancer who doesn't have lymph node involvement does not need an axillary clearance and does not need to have the morbidity associated with it. We're also very lucky at Barts is that we've got a very active and progressive outpatient nursing team, and all the drains now, we're now discharging patients with drains because of the 23-hour model. Drains are being taken out by them. Both of them have mobile phones, so the patients can ring up. If they have a problem with the drains, they'll just come up. If they have a problem with the seroma, they'll come up. If they have a problem with the wound, they'll just ring up, and the nursing staff at Barts will just deal with it. And if there's a problem, one of us or the juniors will get called to sort it out.
A lot of women will need chemotherapy, and I know our letters to you are littered with acronyms and abbreviations that often may not be clear, but essentially what we're looking at is between 4 to 6 months of therapy. Treatment is given every 3 weeks on a cyclical basis. And I've just put up there some of the regimes on a very simple level. They will all have an anthracycline-containing regimen, so either one at the top. And those women that are higher risk will add in a taxane, and that is the most intensive combination in terms of toxicity. So, what may they come to you with? Well, I've put in red there the most important thing, really. Obviously, chemotherapy is being given to prevent the cancer coming back. It's killing off the cancer cells, but it kills off all their normal, rapidly dividing cells. And the most important ones are the ones in the bone marrow, and so, of course, they're at a risk of infection. The other sorts of side effects they come to you about, mucositis, that will occur in the first few days. Again, we can give them mouthwashes for that and do. Nausea and vomiting for the breast cancer regimes, that doesn't tend to be a huge problem. And again, we can advise on the best antiemetics to use. Bowel disturbance doesn't tend to be huge. With the chemotherapy, they will all lose their hair. But there is something called a cold cap that they can use, which is essentially like a very cold helmet that they can wear. They wear it before the chemotherapy, during and after the chemotherapy, and it protects the scalp and prevents hair loss in about 50% of patients. So it's something that's quite, if hair loss is something that's very important to patients, it's certainly worth giving that a try. Specifically with the taxanes, they get muscle aches and they can get a peripheral neuropathy. And I think certainly patients often come to you complaining of these significant muscle aches. And the key is that they can have painkillers. You know, if they get severe muscle aches, and some of these women on taxanes will need codeine, and they can have obviously sufficient analgesia. Often there's a concern that they mustn't have analgesia, they mustn't have paracetamol because of masking infection. I think the important thing is, if there's any worry about infection, ask us. If there's pain, they can take painkillers. The medium-term side effects are fatigue. That is obviously cumulative. And the things that, again, they will come to talk to you about are the menopausal symptoms. Obviously, young women receiving chemotherapy, a number of those will go through a premature menopause, and hot flushes are a very troublesome symptom. Infertility is another obviously very important thing for young women receiving chemotherapy for breast cancer. We have a very good relationship with our fertility specialists, but unfortunately in the current economic climate it's getting increasingly difficult. But patients that need chemotherapy that haven't a family, we can refer for essentially IVF, and they will store embryos ahead of the chemotherapy, and we have a good working relationship with the obstetricians and gynecologists, and we can organise that in a timely fashion. But unfortunately, those women who now have, say, already have a child, it's not possible to offer that now on the NHS. And then the late and very rare complications are heart failure. Again, I think these are very rare, but I think are important again for general practitioners to be aware of, because a woman coming to you with signs and symptoms of heart failure, having been treated for breast cancer, this may well be induced by the chemotherapy, and she should be referred off to a cardiologist. It's very rare. So I think don't be overly concerned, but it is something to be aware of. And similarly, with the risk of leukemia after anthracycline chemotherapy, very rare, but it can happen.
In the MDT meetings, the role of a CNS is to act as a patient's advocate. So in our relationship with them, we might have an awareness of what psychological issues they have, what their social situation may be, and that can play a huge part in how they get through their treatment and the decisions that they make. So it's very much our role to sort of speak up on their behalf in the MDT meetings when we talk about what treatment decisions we think these patients should be offered. One area that we're aware of that we tend to fall down on sometimes is actually supporting the family members and what their needs are, and that's something that we're trying to improve on all the time. For younger women, if they are having chemotherapy, there may be, as Dr. Roylance has said, huge issues with regards to fertility. So it's our role to have those conversations in support with the consultants and refer on to fertility if we need to. Young women also adapting to going through the menopause if they're going through chemotherapy. We're forcing them into a menopausal status, so that can take a huge adjustment for women. In supporting patients, a lot of what we do is referring to other support networks that are available in the community, of which there are many, but unless they get told about them, they don't know. At the end of their treatment, patients often feel that they should be feeling like they've achieved something and that they should be feeling back to normal. The reality is that it's actually at the end of their treatment that a lot of women actually start to feel the impact of all of the side effects, whether it be from the surgery or from the chemotherapy. They're getting back to adjusting to work, or they're adjusting back to being the role within the household of the mother or the wife. And that can be really difficult because for them at that stage, the fatigue is a very big symptom from a build-up of all of the treatment that they've had. Follow-up can be a nerve-wracking time for patients that have gone through treatment for breast cancer because their appointments are fewer and far between. So when they're at home, they worry, they're anxious. They might be experiencing side effects of the endocrine treatment, such as joint pain, which is obviously common, but for them that's a fear that the cancer's come back elsewhere. So our role is very much about educating them about the realities of the side effects and what they might be experiencing to reduce their anxiety.
That concludes this webcast on breast cancer. This is part of a series of 10 webcasts available at this address. The Small C campaign aims to improve cancer survival through better public awareness and early diagnosis in East London. You can find out more at this address. And you will find more useful information on these websites.